Glad I can make a difference. If for nothing else, just my
You are the
presence.
important one.
Sorry for
Oh,
my tardiness. I stuck in a meeting.
no worries. We haven't started yet. So, Fergus, we are recording, so you can go ahead and start the meeting at your leisure.
All right. Thank you, everyone. I'll call the meeting to order of the Rural Regional Behavioral Health Policy Board for June 4th, 2025. And Valerie, if you would just take a roll so we have it on the recording and in the minutes.
All right. Chair Fergus Lothridge,
Present.
Brooke O'Byrne,
Here.
Senator John Ellison, Dr. Erica Rist,
Here.
Matt Walker. He is excused. He did let me know that he's going to try to call in, but he is traveling. Amanda Osborne,
I'm present.
Chris McCann.
I'm here.
Awesome. Thanks, Chris. Patrick Rogers,
Present.
Sarah Dearborn,
I'm here.
Bryce Shields, and Jerry Sanders is excused because I believe she has retired.
She has.
So good for her.
Okay. So we have a quorum and
Yes.
we'll proceed. Next will be public comment. For those that are on the line, we have many people joining us today. If you could limit your comments to 3 minutes. Again, we will not be able to take action on those. But if you would like to address the board, you're more than happy. And I see one hand up now from Molly.
Hi, everyone. Thank you. This is Molly Rose Lewis. I'm with Senator Jackie Rosen's office. I am the healthcare outreach person for all of Northern Nevada. I have another colleague, Beth Morrissey, who is our sort of appointed rural person as well, who does most of our traveling out to the rural areas from our Reno office. Just wanted to introduce myself and Beth, who may or may not join later, but we are both here, and we're happy to speak a little bit more at another meeting down the line if you'd like, about kind of how our office can assist with constituent services, things like assistance with Social Security, Medicare, and other federal agencies, and what other kind of services we provide. But I just want to mention that we can help with federal agencies for folks in everything from individual issues to grant support to things like that. And I am also just here to hear from you and pass along policy suggestions to the federal level. So thank you so much for having me. And I know that the chair has my, or the organizers have my contact information if anyone would like it. Thank you so much.
Thank you, Molly. Sarah?
Thank you so much. This is Sarah Dearborn for the record, and I just wanted to highlight Nevada Medicaid's June 24th public hearing that will be held at 9 a.m. Those meetings are open to the public, but Medicaid will be presenting and seeking approval to submit a state plan amendment related to peer support services, as well as presenting a brand new Medicaid Service Manual chapter specific to peer support services that really goes into detail around adult peer support, as well as family peer support and youth peer support. So all really great services coming our way. And if you're interested, the draft policy is all posted on Nevada Medicaid's public website as well. Thank you.
Awesome. Thank you. Sherilyn.
Thank you, Fergus. Sherilyn Marwood, Regional Behavioral Health Policy Board for the Northern Region. Just wanted to state that AB 60 did pass. It's on the governor's desk. So we did codify certified prevention specialists. And I do know that once session is over and everybody's had a time to breathe, the NCB board, as well as certified prevention specialist, and the coalitions will get together to write those codes and regs to really define their positions. I think it was a perfect timing for that, the codifying of certified prevention specialists with the state wanting so much oversight and things of that nature, and with other bills and other departments being cut that kind of do the work that prevention specialists do through the state. So excited about that. Just wanted to share that. I also want to share that tomorrow is the Northern Regional Behavioral Health Policy Board at 2:00. There will be two versions, hybrid, in person at Lyon County Human Services off of Lake Avenue in Silver Springs, and then again on Zoom. And you can go to nvbh.org to look that up. So hope to see people at the Northern Regional Board tomorrow, even though this is the rural region. We do work closely together. So thank you for that time.
Thank you, Sherilyn. Congratulations, by the way. Okay, other public comment before we move along. Not seeing any hands raised, we'll close that and go to item 3, which is the review and approval of minutes from our April 2nd, 2025 meeting. Those were distributed by Valerie this morning in email. Had a chance to look through them. I hope you have, and I'll entertain a motion to accept as presented or any modifications.
This is Brooke. I move to accept and approve the minutes.
Okay, I have a motion, and is there a second? I believe this type of format, we have to have a second, so.
For the record, this is Patrick Rogers, and I will second that approval.
Thank you, Patrick. All those in favor, say aye.
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 Or easier in a group setting like this, any opposed? Hearing none, thank you. We'll be able to get those posted up now as adopted. Item 4 is discussion and possible actions regarding the proposed behavioral health policy and programming position stands for the Rural Regional Behavioral Health Policy Board. This is an area that Valerie and I have communicated with a little bit to help just kind of carry the torch when we're not in meetings to some of the kind of position statements of where we stand on things. So it'll help us communicate with other folks. And also, as things go through reorganization coming out of the legislature, it would be ideal for folks coming in to be able to see just where our rural components stand on some of these behavioral health issues. So Valerie, I'll turn that over to you to lead that one off.
Thank you. For the record, Valerie Haskin, Rural Regional Behavioral Health Coordinator. Ultimately, a position stand, for those of you who may not be familiar with them, are supposed to be very brief descriptions of an organization or body's position on a specific topic. And so as Fergus and I were discussing what we could do to maybe help get the perspectives of the board out in kind of the system itself a little bit more, as well as maybe help those policy priorities that you've already developed and approved really kind of help guide future programmatic building, is if we have some position stands that represent what you as the board believe to be what course of action should be taken when implementing evidence-based practices, best practices, what makes the most sense for policy in the context of rural communities. And so with that, I did put together a list of different topics, which we'll get to in a minute. But first, I wanted to bring up the first position stand. Oh, wait, I need to cancel that. So this was, let me make sure I have this up correctly. My apologies. So I wanted to go with something that we've discussed at length in several different meetings throughout the years and in different policy priority issues. And so this one is really looking at telebehavioral health use in rural communities. And now that I have that up, I can share it so that everyone can see what we're talking about here. And so what I wanted to do was to have something like this that we could share pretty easily with our community members. So this, utilization of telehealth for behavioral health treatment in rural and frontier communities. And this is something that aligns with your policy priority areas of access to care, as well as quality of care, because some of those two things are the pieces that come up most frequently when we've talked about the use of telehealth. In previous conversations in previous years within the board's work, the use of telehealth has been kind of a fluctuating point, right? So previous to COVID, I talked to many people out in the communities and even some of the board members where, there was a lot of concern about the shift towards the use of telebehavioral health. In the post-COVID world, having access to telehealth has pluses and minuses, same as in-person care, particularly when we're talking about small communities with not a lot of transportation. So I'm going to go ahead and just read this so that the people online and our participants can go ahead and see this, or can understand what we're talking about here. So the summary is essentially the overall position. So the Rural Regional Behavioral Health Policy Board stance is that both in-person and telebehavioral health care should be included in federal, state, and local plans to expand the array of behavioral health treatment services for rural and frontier Nevadans. While policymakers and program development staff at federal and state levels may be tempted to lean on telebehavioral health as the primary solution to expanding access to behavioral health services in rural and frontier communities, both the current body of research and anecdotal community member preference require the inclusion of both in-person and telehealth service delivery modalities to meet the needs of residents of these communities. Just to start out with, does that sound like it's in line with the feelings of the board? Okay, I see Fergus nodding his head. Anybody else? Okay, Patrick is nodding. He's a provider. Erica, anybody? Okay. I'm seeing nods. All right. So with the introduction and background, I dove more into provider shortages and the evidence behind that. I also was able to find some really great papers in Open Access regarding the efficacy of telebehavioral health and how it can be really appropriate for some outpatient treatment in some conditions, but the efficacy isn't really well known in some other contexts, including more long-term and acute care. So that is where this introduction and background focused upon. So as the whole of Nevada experiences shortages of all types of healthcare providers, clinicians providing treatment and services for mental illness, substance use disorder, and co-occurring conditions, or behavioral health, are even fewer, particularly in rural and frontier communities. Thank you, Rural Health Data Book. This lack of providers is compounded by large geographical distances between communities and insufficient public transportation options among them, creating sometimes insurmountable barriers for community members to physically access care. To overcome physical access challenges, many federal, state, and local agencies have looked to the use of telehealth as a solution. In the wake of the COVID-19 pandemic and its associated shift towards utilizing technology to improve connection to treatment, the efficacy of telehealth for mental health and substance use treatment has been further studied and is considered effective for many types of mental health conditions, including anxiety and depression. Additionally, there is evidence to suggest the effectiveness of the use of telehealth in the treatment of substance use disorder, including opioid use disorder. Not only does the use of telebehavioral health assist with overcoming physical access barriers to care, but there are other benefits as well, including, but not limited to, improved real or perceived privacy in small communities. Nobody has to worry about their car being parked outside of the clinician's office or, being seen seeking treatment. Broader access to services across the behavioral health continuum of treatment. So, for example, if somebody wants some sort of specialty care, they may be able to find it outside of their community and access that via telehealth. And the third point here is mitigating ethical practice concerns related to provider residency in small communities. I've heard from some of our providers that they've heard it's unethical to have any contact with their patients outside of that clinical environment. And it's also unethical to treat anybody who they may have contact with outside that clinical environment to begin with. Unfortunately, if someone is the only provider in a community, that doesn't really serve the community very well. Okay, next one. However, telehealth is not a universal solution. Research in this area is still limited, and effectiveness of telehealth for behavioral health treatment appears to be dependent on the context in which services are provided, as well as the types of conditions being treated. Additionally, barriers such as discomfort with technology, lack of stable internet access in rural and frontier communities, and exacerbation of isolation in certain populations may further limit its appropriateness or effectiveness as a broadly used treatment delivery option. There is concern among rural stakeholders that decision makers, particularly those unfamiliar with rural challenges, may over-rely on telehealth as a catch-all remedy without fully assessing its suitability for all circumstances. All right, so Rural Regional Behavioral Health Policy Board's position on the utilization of telebehavioral health. The Rural Regional Behavioral Health Policy Board, hereinafter referred to as the board, asserts that expanding access to behavioral health care in rural and frontier communities requires a balanced approach that includes both telehealth and in-person services. Given the personal and varied nature of behavioral health conditions, systems must offer a wide range of modalities and specialties statewide. Patient screening and service coordination should capture treatment preferences, and systems must remain responsive to changes in those preferences and to the evolving service landscape. In that context, patient preference for in-person or telehealth service delivery should be honored to the extent feasible, and best effort should be made to connect patients to the care they prefer when appropriate and available. So somebody may want to have in-person only, that may not be available, but whatever we can do to make sure that that person does get connected to in-person treatment, if they continue to prefer that, would be appropriate. Additionally, telehealth and in-person services can be utilized as mutually supportive within a patient's treatment plan. One example might be the use of electronic platforms to participate in anonymous peer support groups between in-person counseling sessions. Conversely, in-person peer support groups can be used in conjunction with treatment received via telehealth. Although telehealth addresses many access challenges, it should not be treated as a singular long-term fix. Ignoring its limitations and patient preferences may undermine service effectiveness and the value of public investment. In conclusion, the utilization of telehealth or in-person services is not a binary choice in program development, and both modalities of treatment delivery should be considered when designing policies and public serving programs to bolster access to behavioral health care in rural and frontier communities. Thoughtful blending of delivery models should be prioritized during treatment planning to ensure care is tailored to individual needs. And then on the next page, we have the references. So board members, what are your thoughts? Does this reflect the board's position? And is the board comfortable with having publicly available position stands like this?
Valerie, this is Patrick. I have a question on this. Let me go back to your final question. Is this something that the board would support of having some sort of a policy in place like this? I would say yes, because I think it addresses a very large issue that we're dealing with on a day-to-day basis in our rural areas. I think it's very clear to say that there's no perfect system. And I think that's an important piece that we have to blend the models. But my question is that when we are talking about behavioral health, I think the assumption here is that we're talking about the therapeutic talk therapy, CBT, whatnot, and we're not talking about behavioral health in the sense of psychiatry for this, right? Now, sometimes we leave that out, but that's an important part of treatment, especially in a rural area. And that we may want to be able to reference that and saying, okay, this is also addressing the psychiatry side of things, which is a medically assisted, the medical side of things. Or does that fall into more of a medical model?
That is, that is something that I hadn't considered in my non-clinical brain. The medical side of things, I mean, they kind of flow together, but I'd love to hear more about that differentiation.
Yeah, I think we may want to just add in to something like this about kind of definitions,
Okay.
right? As you do with a lot of policies, there's always the definition of what we mean when we say behavioral health provider? What does a behavior, what are we talking about licensures and who are they? And then saying that this is also includes the psychiatry, which is the medical component of behavioral health treatment. So something that, to make sure that we're covering all of our bases is my suggestion.
So, Dr. Rist, I see you have your mic off. Is there anything else you'd like to kind of build on that?
Yeah, I would agree. It's interesting. I mean, it just speaks to how people interpret different terminology. I made the assumption that, telebehavioral health covered all forms of behavioral health, which includes both therapy and medications. But I completely agree with Patrick that since people do interpret terminology differently, I think it's important to provide definitions to be really clear about what we're talking about. So yeah, totally agree with that. In terms of your questions, the first question about whether we should have, general policy statements like this, I think is a great idea. And I certainly agree with the statements that have been made in this document. One sort of thought or suggestion, there's a lot of weight in this particular document on patient preference as the reason why we need to have alternatives to solely telehealth, which certainly patient preference is a very important piece. But I also think that from some clinical efficacy and ethical standpoints, there are other reasons why sometimes telehealth is inappropriate. Two that I can think of off the top of my head. So I have seen a number of situations where very young children have been prescribed psychiatric medications by a telehealth provider who really hasn't even laid eyes on the child because the child is literally, hiding under the desk and, maybe not engaging with the TV screen. And so the decision to prescribe is based solely on parent report, which is not good practice. So I think that there are certain age populations where in-person is preferable to telehealth for clinical reasons, and particularly young children. And then the other, I think, real advantage to in-person as opposed to telehealth is that telehealth providers, particularly if they're from another state, frequently don't understand the cultural context and the resources that are available in the local community. And so I think that there are some situations where it's preferable to have an in-person provider to understand the local cultural context. So, so I guess my recommendation is just let's strengthen it a little bit so it's not just about patient preference, because I think then often the response is, well, we just need to get people more comfortable with telehealth. And in fact, there's certainly lots of great advantages to telehealth, but as the statement points out, we don't want to lose options of in-person, and we don't want to exclusively limit people to telehealth. So those are my 2 cents.
Thank you. Sarah, I see your hands up.
Yeah, so to answer your specific question on like policy stances, I think it is a great idea, like others have said. I know from my perspective as a policy writer, I think leaning on and engaging our communities on specifics of preferences, I think would be really helpful as we're working, at least from the Medicaid perspective, from developing new policies as well. I think it's definitely great engagement to have. Specific to some policy stances, I may have to abstain here and there from certain policy stances, but for this one in particular, I agree with what's been said as well. I know in our Medicaid policy, we've had some difficulty around this before, and so we've leaned on kind of what Dr. Rist was talking about is clinically appropriate and medically necessary delivery of services. So maybe including something around that. But then also just speaking to the use of policy stances on helping inform policy development. We've recognized the struggles that our rural communities have in providing access. And so for Medicaid to think of incentives for on the reimbursement side of possibly providing financial incentives to providing more access in our rural communities, like those are all great things to think about and incorporate. So I think the policy stances are great.
Thank you, Sarah. And Patrick?
Thank you, Sarah. I think that's great feedback. Thank you. Dr. Riss, to your point, and I may be getting too far in the weeds on this, and I don't want this to kind of necessarily change the document, but you're talking about age appropriateness, and I think there's also diagnosis appropriate as well. There are diagnoses out there that are, I'll say, technology adverse, if we read in that right. We oftentimes have to have patients pass what I refer to as the smell test as well. So there's some, rules of the hygienes and are people taking care of themselves? We can't necessarily see clothing as much. So I think, again, that is how do we do that in telehealth in general? Right. I mean, it's really passing that. But I think to your point is saying, where do we draw the line of saying, do we say that certain ages would be appropriate and certain ages wouldn't? Would certain diagnoses be appropriate and certain diagnoses not? So that I think would be my comment as well, that we're not going to reach the people that we need to reach if it's going to be telehealth because they're just not going to want to be online.
Absolutely. And I'm thinking, for example, of some psychotic disorders where folks have very specific fears and paranoia around the use of technology. And those are often the ones that, need the help the most. So we don't want to exclude all behavioral interventions or, only have them be telehealth because they're not going to meet the clinical needs of all the different populations, both in terms of age and diagnosis. I liked Sarah's terminology. I can't remember exactly what you said, Sarah, but I think for the purposes of this document, Valerie, just including something that says it's not just patient preference, but also clinically effective, clinically appropriate and efficacious for the population and diagnosis served or something like that.
Okay.
Yeah, I think if you go back to when you play back the tape on this, and Sarah had it kind of rang with me, just I think it did is Dr. Riss there, and that would fit into the second paragraph of the board's position. Do some wordsmithing in there with that, and then also going to Patrick's initial comments about the psychiatric care coordination, and that being into the third paragraph. So not to wordsmith this today, excuse me, but I would suggest that Valerie individually, not as a group, but individually you work with the professionals that we have on our board in this area and maybe have it ready for prime time at our next meeting in August.
Sounds good to me. I love that idea. And then on that, if we want to have maybe a couple ready for prime time and just maybe batch them or what that might look like, I wanted to share a list of additional position stand topics that I developed. I did take the telehealth one off since we were discussing that today. So we can add this back in, but other topics that we were considering, interstate licensure compacts. We know you guys really like the idea of having the social work compact. So, anything we can do to potentially support further efforts later down the road on that and having a why. There was some interesting anecdotal information that came up about interstate licensure compacts during session that maybe we could explore a little bit further through a position stand, such as, in the places where there are interstate licensure compacts, any concerns that systems were all of a sudden flooded with providers and unions were no longer able to participate in collective bargaining is not founded. Again, we can look for evidence and make sure that that statement is factual and maybe include that in a compact and a position stand. Because that was one of the major issues that we ran up against. Other ones, coordination of care across the behavioral health treatment continuum, structuring utilization of mobile crisis response teams. There's a lot happening with that right now. Behavioral health considerations in local emergency response and disaster planning. The state is currently working on the Bipartisan Safer Communities Act component regarding including the behavioral health considerations into state planning. So what could that look like at the local level? Transportation to acute/inpatient and outpatient behavioral health services, school-based prevention, school-based mental health training, CEL, MTSS, and other supports, school-based suicide prevention, crisis response, postvention, and communication strategies, community-based mental health awareness and suicide prevention strategies, use of criminal justice system diversion programs and specialty courts. Again, these are very broad topics that you can get very specific on if you want to. Discharge planning from crisis or acute behavioral health services for rural and frontier residents. This was actually the first one I worked on. And it turned out to be a very large project as I'm kind of digging into things and making sure that like, okay, what does it say? You know, what does HCQC have to say about this? Where is it in statute? Where are the NAC associated with that? I was able to have get some really great information from HCQC, but I'd love to work with Sarah on this, as well as everybody else as well. There's not a lot in the way of standardization for discharge planning processes, and maybe that's kind of where that goes is, you know, what are some basic components that should always be included? Community-based overdose prevention strategies, community-based substance use prevention strategies for youth, same thing for adults. Community-based recovery support strategies, the importance and roles of parent engagement in behavioral health prevention efforts targeting youth, engaging faith communities in prevention, treatment, and recovery, use of certified prevention specialists, which were just codified. As Sherilyn, my counterpart, mentioned earlier in public comment, that was codified with AB 60 this session. So hopefully we'll see more of those. Community health workers, certified peer recovery support specialists, and other paraprofessionals. Use of evidence-based and culturally competent community-based strategies to reduce access to lethal means during mental health crisis in rural and frontier communities. That there were several bills that looked at that in the terms of firearms this legislative session. Best practices for suicide prevention among veterans, service members, and families in rural and frontier communities, and supporting behavioral health of first responders, and behavioral health crisis intervention training for first responders. So those are just some topics. So what I'd love is if there's at least maybe one other topic that you'd like to choose for that August meeting that I can prepare another draft for, and maybe have work with some of you on preparing that draft, work with some of our community members and make sure that it's appropriate and robust, and have that ready for the August meeting. That would be fantastic. So board member thoughts.
Valerie, can I propose, this is an exhaustive list and some are seeing it for the first time. Maybe a little difficult to come to a conclusion on something right now. If you could take these and distribute to the board in like a poll or something with a, here's the title and a kind of an opening line of why you picked that one to highlight the title of it and let them do 4 or 5, or 3 maybe, just try to keep the bandwidth narrow and then focus on those as the priorities. Would that help at all, or is that confusing the process? Just
So
thinking in the interest of time today, seeing this for the first time, and not having time to dwell over it.
Yeah, so for the purpose of open meeting law, if we do a poll, I need to bring back the results of the poll to the meeting before anything is done. And so that it can be kind of an open discussion, if that makes any sense. So we can, I can put it out via SurveyMonkey, and then I can bring the results of that SurveyMonkey back to the August meeting and say, okay, so here were the top 5. Are you guys in accordance? Are there any specific details? And we could maybe do that.
I'll leave it to the board if you want to act on it today, or if you would like to have some time to mull that over.
This is Brooke for the record. I do think this is a long list, and I think it makes the most sense to prioritize the policy stances that are going to be the most utilized in the short term. So I don't know if that's helpful to the poll discussion, but I do think as we look at which ones we want to focus on for the August meeting, that could help us narrow the list down a little bit.
If I may, Brooke, to add on to that, and the audience to which this would be beneficial for. As you do a position stand, here's what we're trying to convey to a receptive audience, to try to let them say, this group says, and we support, and so we're moving forward with. Other comments from the board? Patrick, you had your hand up?
Yeah, I guess I'll just throw this in there, and I don't know how we want to take this, but I look at a lot of these bullet points, and a lot of them are programs and support that takes people. And right now, one of our top concerns is workforce. And that's why I think for me, I would probably be zeroing in on the interstate licensure compact. Because none of these, I shouldn't say none, that's a very black and white statement, but many of these are going to take personnel, and it's going to take professionals to be able to do this. And if we don't have the professionals, especially in the rural areas, we're not going to be able to follow through on some of these programming pieces. So that for me, I look at this and say, these are all really important, but without the people, I think we need to really be looking at professionals. So I would zero in on the interstate licensure compact. That's my nickel.
And Patrick, to your point, the other one that is very workforce development focused is the use of paraprofessionals. So the certified prevention specialists, community health workers, and peer recovery support specialists. So I realize that Erica has her hand up too, but I would just maybe think about, do we want to look at maybe drafting something about interstate licensure compacts and use of paraprofessionals in Nevada, and those two as like the 2 additional ones that can be brought to the August meeting? I'm sorry, Erica, please go ahead.
Yeah, I agree with Patrick for a different reason, but so I'll add my 5 cents and make it a dime. But another reason I think to pick the interstate compact as one of the first ones is that we've already done a lot of work on that topic, right? With our bill that wasn't successful, but I'm sure, Valerie, you have lots and lots of documentation and things, so it won't be as big a lift for some of these newer topics. So I think that also is a reason. And then almost similarly for the certified prevention specialists, since that was a successful bill that just got passed, it's an opportunity to really support and reinforce the results of that bill. So I would echo, I think that both of those two are a good place to start.
Great point. Other comments? So Valerie, how about work on those two?
So,
and
okay.
see what you can come up with.
So I'm hearing that there's the opportunity for a motion to be made that would direct me to have final drafts of the telehealth position stand, the interstate licensure position stand, and the paraprofessional position stand prepared for review and vote at the August meeting.
In my
Chris
mind, I
McCann,
thought
so
that's
moved.
what Patrick was doing and Dr. Rist was seconding, but you know, it's Robert's rules.
I just heard Chris say something.
I was just saying that sounded like a good motion to me, so I'll say so moved to what Valerie said.
Okay.
And since my microphone is on, this is Patrick. I will second it.
Thank
Love
you.
that. Thank you. Any opposed? I'll go that route. Hearing none, we got it. Is Linda Anderson still on? My days with working with Linda in the AG's office, it's probably just cringing now at the way I conduct a meeting. Sorry about
You
that.
did it perfectly, Fergus. It's
Okay,
very
all
good.
right. Thank you, Linda. Oh. You always got to know your audience, I guess. Okay. Other discussion on that, item number 4. So we agree there's some things we need to work on. We have the one on the telehealth. It's going to be fine-tuned with some work with Valerie and between Sarah, Patrick Rogers, and Dr. Riss, and we'll get that fine-tuned and ready for prime time, and then some drafting on some things on the other 2 that we agreed upon, and then see where we go from there. Okay. Any other questions on item 4? We'll move this along because it's getting later. Item 5 is kind of is our placeholder for projected changes to the behavioral health system and programming affected by bills passed. This is basically our legislative review. Valerie had sent out some information this morning. You know, we're somewhat at a limbo on some of these because of the things that happened at the 11th hour in the legislature and Nellis crashing and trying to get information out of that to appropriately brief folks. But I did ask Valerie to give us a brief overview of some of the areas that she knows as factual right now today. And I want to also take this time to commend Valerie again on behalf of myself and the board that for her efforts during the legislative session to keep us informed and working the halls and the phone calls and meetings that she had to drop her life at the last minute to be able to make. So Valerie, hats off to you for that support to our board. So with that, I'll turn it over to you for a brief summary, and we'll have more on this in detail in August.
Thank you, Fergus. Again, for the record, Valerie Haskin, Rural Regional Behavioral Health Coordinator. So the session did close sine die. It was technically yesterday morning at 12:35 in the morning. There was a lot of commotion, a lot of last minute movement on things that seemed like they were maybe dead in the water, and then also some other things. So we know that, as Sherilyn mentioned, we know that Assembly Bill 60 from the Northern Board did pass. So again, codifying certified prevention specialists. Unfortunately, it appears that Assembly Bill 31 from the Southern Regional Behavioral Health Policy Board, that's the one that would improve Medicaid reimbursement for quote unquote non-emergency behavioral health transport. So that term is unfortunately a little bit misleading because it would be for behavioral health emergencies and crisis, but it's billed as, or it's called non-emergency because it's not a physical or medical emergency. So unfortunately that bill did pass. Basically, if something had a large fiscal note, generally speaking, it got put on the back burner and may not have made it. Senate Bill 78, which was the business and industry bill that would have consolidated occupational licensing boards of all types across Nevada, as well as initially proposed to consolidate or sunset or otherwise remove other committees and advisory boards, such as the regional behavioral health policy boards, also did not move. It appears that no bill passed that would consolidate the occupational licensing boards. And so our functions are the same. The occupational licensing boards are the same. We'll talk about that a little bit more during my coordinator update. Also, the Washoe Behavioral Health Policy Boards bill did not pass. There may have been some other bills that also looked at insurance parity for mental health, but unfortunately, every time, as Fergus alluded to, every time I try to get into Nellis to see what the final status is of bills and or the final language if they were enrolled, Nellis crashes because apparently everybody else in Nevada is trying to do the same thing. So again, hoping that we will have more information for you at the August meeting about those pieces. And I think that's about all I have that is absolutely known fact at this time. Any questions at all?
Thank you, Valerie. We'll look forward to further discussion and presentation on this in August.
Oh, one quick thing. So there was last minute movement on Assembly Bill 163, which was Assemblyman Hafin's bill that would enter Nevada into the Interstate Licensure Compact for, or I'm sorry, it was the Counseling Compact, which is the compact for clinical professional counselors. Again, trying to get more information on that. Some places on Nellis, it looks like it may have passed. However, in other places, there's no language as, indicated as enrolled. So hopefully we can get more information. I don't know about you guys. I personally would rather see one compact pass than none. But again, hopefully we can revisit that if necessary at a later date. My apologies.
No, that's a great point. We were supportive of that, and just difficult to know its current status, even a day later. So we'll keep abreast of that. Next, Valerie is going to I'll turn this over to you again for your update regarding some of the activities, resources, and challenges that you're encountering at your usual spot. And take it away, Ed.
All right. Again, for the record, Valerie Haskin, Rural Regional Behavioral Health Coordinator. I will try to make this quick. So I will distribute this with the rest of the materials so that you guys have record. So one of the big things that happened pretty recently since our last meeting is actually Elko County is looking to launch a new mental health court this summer. And in preparation for that, one of the justices of the peace wrote and was awarded a grant for a sequential intercept mapping workshop in Elko about 2 weeks ago now, I think. And that was really interesting because it kind of brought forward a lot more of the discussions that we'd had previously in the behavioral health task force there. But this time really including court staff and the justices. So it was a little bit different audience. So there's renewed momentum there for a MOS team, improving data collection and reporting, looking at care coordination, particularly for people who are justice involved, and also building multi-sector training plans for all first responders. So that's pretty exciting. I went to the RX Summit in Nashville at the end of April. Tons of information, really fantastic things. I was able to download a lot of the presentations. So if you have any questions about anything, if you saw the agenda and maybe weren't able to make it, please let me know and I can try to get you that information. I will be hopefully traveling to Anaheim in August for CIT International. And that is it for my like major travel that's really planned at this time. Kind of covered that piece. So we also talked a little bit about legislature. So general admin projects. I'm working on a behavioral health provider crosswalk. I did mention that last time. It is kind of in its final draft format. I'm going to actually hold a stakeholder meeting with the licensing boards and other partners to really go through it with a fine-tooth comb and identify whether or not these details are correct before posting publicly. And this is really something that compares the different provider types with, the first section is what education is required, how many internship hours, who oversees those internships, what is the licensing or certification body. So those different pieces just for comparison. And then also, all right, then moving down, what can they do? What is their proposed scope of work? And really what's the best utilization of their space? And then also looking at, because even though within that there are differences. So for example, LCSWs, CPCs, and MFTs tend to be used somewhat interchangeably. However, their education is different. And people may have different backgrounds based on some of that coursework that happens at the graduate and undergraduate level. So really kind of what's the primary focus of that provider type, even if they can do all different types of work with different people, maybe what's maybe the best context, if that makes any sense. And that's not just at the master's level. I look at that, the paraprofessional through, I believe, psychiatry. I've also been working on building some shared folders. You'll notice in my email signature line, there's a link at the bottom that goes to a link tree. I've got a little photograph that's a screenshot there on this report regarding the different links and things that are available. So that's, information about the Nevada opioid settlement funding and the Fund for Resilient Nevada. A link to OD2A data and reports, Nevada DHHS Office of Analytics reports, et cetera, and different things. And that's also included in all of the social media channels instead of just having the website posted. There's, of course, a link to the website as well. I've been participating in 988 in BISCA things as needed. So with the BISCA, I was able to lead the charge on preparing a training listing of what types of trainings would be appropriate for emergency managers and their teams in preparing for the inclusion of behavioral health strategies in their emergency management plans. Also identifying means to complete the opioid needs assessment in ELCO. So unfortunately, I know Amanda has a ton on her plate. And so to help her out, I was able to reach out to the Nevada Office of Rural Health. They may have someone or a couple of someone's who could be interested. We'll see how that goes. But we are trying to make some movement on that. The thing about having the opioid needs assessment in place is even if Elko County or none of their different offices are going to apply for the State Fund for Resilient Nevada funds, if any nonprofit or other NGO is interested in applying and they're going to be doing work within Elko County and potentially kind of touching county offices or even city offices, that needs assessment does have to be in place in order for those applications to be eligible for funding and awards. So just trying to kind of clear the way for some of our other local stakeholders to move forward with some of those strategies. I do have opioid rescue kits that were purchased by the Overdose Data to Action or OD2A program. They are in a weatherproof box. I want to say there's about 6 different bags within each of those boxes. It's like a canvas bag. It includes 2 naloxone doses as well as fentanyl test strips and xylazine test strips. Just some quick notes on technical assistance, because I am required to give you technical assistance as per my scope of work. So here you go. The best practice when you're using naloxone or other overdose reversal medication at this time is to focus on really getting the person resuscitated back to breathing, not necessarily consciousness. So sometimes they may start breathing and it may be several doses again until they resume consciousness. If you give them those additional doses, it may put them into a state of withdrawal, in which case they may be more likely to immediately go out and use again. And we want to take that that time immediately after an overdose as an opportunity to get them potentially into care, if possible. Also with the rescue boxes, as well as any other overdose reversal or harm reduction strategy, it's always best to have them somewhere where people can access them 24/7 without having to ask someone for them, just so that they can take care of the emergency in the moment and they don't feel further stigmatized. I had my site visit for OD2A. Everything was on the up and up. I recently joined the NAMI Northeastern Nevada Advisory Committee, so really excited to future work with them. I've also been working with Silver Summit Health Plan's behavioral health kind of coordinator, trying to get some contacts at CareSource in ways that we can really start to leverage the rollout of the MCOs to improve care continuity, and make sure that those are set up in a way that will really serve and help out our rural and frontier community members. They launch for service on January 1st, 2026. Sarah, is that correct?
I'm sorry, can you repeat that?
So that the rural serving MCOs will be enrolling as of January 1st of next year. Is that correct?
Yes.
Okay, thank you. And Silver Summit was, very open to working with us and identifying strategies that can help people out. CareSource is also a nonprofit, so that's exciting. I've heard a lot of great things about them, and I'm hoping that we'll be able to work with them pretty well too. There's also at the summit, or the RX Summit in Nashville, there were a couple of really great models for care coordination in rural communities that came from that. There's one in Kentucky and another one in Eastern Washington, that both had components that could be really feasible for a lot of our communities, and generally leveraged opioid settlement dollars. So that could be another opportunity to find a way to use those funds to create better continuity of care. Other projects I'm going to be working on, opioid, substance, and alcohol treatment referral process mapping. That seems to still be somewhat nebulous. Building and/or distributing resources to assist communities with post-vention efforts in various contexts. So there are some things that are published in Nevada for schools specifically, but what about employers? What about first responder contexts? What about mining? What would that look like? What types of policy changes would maybe these people want to consider? What services would they want to be able to activate, or do we need to build some services to do so? And then also building out training plans for first responders as appropriate. Some system level changes. So Cody Finney, who is the DPBH administrator, is retiring, I believe, the end of this week. Last I heard, Dina Schmidt, previous administrator for ADSD, had been slated to take the position. The Nevada Office of Suicide Prevention has been absorbed into the crisis response system group. This didn't quite happen as it was initially planned. And so I'm going to be working with Rachel to help figure out how we can build infrastructure within our region to get some of that training and TA that the Office of Suicide Prevention created and built and provided, and figure out how to get that at the local level. Federal funding is still very much up in the air in a lot of ways. And so there's a lot of programs at the state level that have really paused their plans for expansion until they have a better idea as to what's happening and what types of money they may have. Right now, the 988 funding and opioid settlement funding are really the only things that we know we have, just because it comes directly to the state level and it doesn't necessarily depend on anything that's happening at the federal level. Also, please note that there is very clear limitations and purposes for that funding, so that's not something that can be used in any way we want. And then at the local level, very recently, the leadership changed at PACE Coalition. The new executive director is Lauren Wynn, and her email address is there. Following up from quality concerns from the April meeting that were discussed, I made a couple of different attempts to contact the COO at the Reno-based inpatient facility that was brought to my attention by one of our hospital social workers in the rural region, that they were seem to be delaying applications for care and admission for patients. I did not hear back from that person. One of my counterparts did get to meet with them. It sounds like there might be some connection issues, but we're not certain what's quite going on. So I did recommend to that social worker that if this is a continual issue, that they may want to consider making a formal complaint through HCQC. And then, as we've heard complaints about licensing boards for several years, given that they were not consolidated, this might be a really great opportunity to work with those boards and figure out how we can kind of work on some of not only the reporting piece that would have come from AB or SB 68, but also, what's going on so we can help maybe people understand what their processes are. Are there any ways that their processes can be improved? And so that is my summary. I'm sorry for talking for 15 minutes about that. Any questions?
Any questions from the board? Lots of stuff. Valerie, will you make that available, or have you made that available?
I will send that out to everybody on the invite list, and it will also be posted with other board materials on nvbh.org after the meeting.
Very good. Great. Okay. There are no questions. We'll go to the almost close out of this, the public comment portion. Had some discussion today, and people have been patiently sticking around and listening and multitasking while they're doing it. And if any questions or thoughts arise, and Sherilyn, first up, 3 minutes.
Sherilyn Rarwood for the record, Northern Regional Behavioral Health Policy Board Coordinator. I just wanted to let you know that I just got off a text with Haveman, and his bill is sitting on the governor's desk. So we shall see, fingers crossed, what will happen. But I reached out to him, and it is on his desk.
Waiting for the yay or nay. Very good. Other comments? Not hearing or seeing anybody raise any hands up. Okay, just a reminder, our next meeting is August 6th. Same time and place. Valerie will be sending out the notice in advance of that, but just a placeholder on your calendars if you haven't already. August 6th it is. Any of the board members have any other comments? Good or the order? 1:10, and you want to get out of here on a Wednesday? Okay. All right. With that, we'll adjourn this meeting at 1:11. Thank you, everyone.